Welcome back to the channel. This week we are going to talk about irrigation in endodontics. If you're new to the channel, my name is Siju Jacob. I've been a private practitioner for the past 25 years in Bangalore and Dubai. I've been using a surgical microscope in my private practice for more than 20 years, and I've been training dentists how to incorporate the surgical microscope in everyday clinical practice for more than a decade. If you've been here before and you found some value in the videos that I post every week, then don't forget to click on that subscribe button so that you get notified every time I upload a new video, which is usually every Sunday. You can also subscribe to my weekly newsletter. I've put the link in the description below so that you get even more useful information delivered right into your inbox every week. To be honest, I never really planned on making a video about irrigation in endodontics, but this happened to be one of the most commonly requested topics over the last 4 or 5 months on our channel. So you asked for it, so here it is, irrigation in endodontics. Before we begin, if you'd like a short PDF that I've put together, which you can use as a reference in everyday clinical practice, then do check out the link in the description below. It's completely free. You can download it on your phone, take a printout, keep it in your clinic, and keep referring every time you have some sort of a doubt with regards to irrigation in endodontics. Do check out the link in the description below. Okay, let's get started. We know for a fact that canals aren't uniform tubular channels. They usually consist of multiple ramifications. Pulp tissue is not one straight tube like a gutta percha cone. You have multiple ramifications, and we sometimes discover this when we treat non-vital teeth and the sealer goes into these ramifications. You don't really find these sort of ramifications many times when you treat vital teeth, but non-vital teeth, we tend to discover these ramifications much more often than vital teeth. So we know for sure that there are so many ramifications like this, and we know that the rotary niti we use will not go into these ramifications, or even the hand instruments for that matter. So we have to rely on irrigants. So it's sort of a understood thing in endodontics that it's the instruments we use that does the shaping, and the purpose of shaping is so that we can introduce irrigants which can go in and do the cleaning. So that's how we look at the importance of irrigants. It is a very important part of routine clinical endodontics. So what are the ideal qualities that an irrigant should have? Well, first of all, it should have a very broad antimicrobial spectrum. It should dissolve pulp tissue and organic debris. It should be a very good lubricant. It should remove smear layer. It should be systemically non-toxic, non-caustic to periodontal tissue. So these are all ideal qualities. Unfortunately, there isn't a single irrigant which can fulfill all these properties in one. Till then, we have to use multiple irrigants in endodontics. Now, I'm guessing that one of the reasons why a lot of the viewers here requested for a video on irrigation is that there's a lot of noise out there with regards to what irrigant to use and how to use. And that's probably the reason why a lot of people get confused. So just to clarify, with the available evidence, there are only 4 irrigants that you need to use in everyday clinical practice. So the most important thing is to cut off all the noise and understand that you don't need more than these 4 irrigants in everyday clinical practice. These 4 irrigants are sodium hypochlorite, EDTA, chlorhexidine, and sterile water. Other than these, in my opinion, you don't need any other irrigant in routine clinical practice. Let's start with the most important irrigant of all, sodium hypochlorite. This is the most commonly used irrigant in everyday clinical practice. First, let's talk about the good things about sodium hypochlorite. Well, it dissolves organic tissue, it dissolves pulp, necrotic material, and the organic components of the smear layer. It has a very broad spectrum of antibacterial activity. It is an excellent lubricant. It is inexpensive. It's easily available and has a reasonably good shelf life. However, it does have some drawbacks as well. So let's look at some of the drawbacks of sodium hypochlorite. First of all, it is caustic to tissues and should be used with caution. Both patient and the doctor should wear protective glasses. Rubber dams should be used to prevent the leaching into patients' oral tissues. This is really, really important. If you aren't using a rubber dam, for God's sake, then don't use sodium hypochlorite. Learn how to use a rubber dam and then use sodium hypochlorite. And finally, forceful extrusion of sodium hypochlorite into the periapical region can cause severe inflammatory reaction. This is one of the major disadvantages. One has to be extremely careful when one uses sodium hypochlorite. In fact, a very good practice to have in your clinic is to use these sort of syringes, the red syringe, whenever we load sodium hypochlorite, so that both the assistant and the doctor, everybody knows that when you see a red syringe, it's sodium hypochlorite. So everybody's on red alert so that this particular solution is not misused. One of the doubts that a lot of practitioners have is what concentration of sodium hypochlorite to use. Well, it depends on two factors: antibacterial action and tissue dissolution. Usually, most clinicians prefer a concentration of 1 to 5.25%. Theoretically, the higher the concentration, the better antibacterial and tissue dissolution properties. However, the more you increase the concentration, the more cytotoxicity, the more risk of tissue injury if extrusion occurs, more post-operative pain, and more dentin alteration. So, one has to strike a balance, because on one side you have 1% and on the other side you have 5.25%, and one needs to find a sweet spot. You don't want the concentration to be so low that it is ineffective, and on the other extreme you don't want it to be so high that all the harmful effects are exaggerated. So one needs to find sort of a sweet spot between 1% and 5.25%, and the jury is still out there. Endodontists are sort of divided. Most endodontists prefer 5.25%, but there are a lot of endodontists who prefer 3% because they say there's not much of a difference between 3% and 5.25%. So 3% seems to be sort of like a sweet spot. So you can use heat to increase the efficacy of sodium hypochlorite. For example, you can use a 2% sodium hypochlorite solution and apply heat and get the same effects as using a 5% solution. So heat does improve the efficacy of sodium hypochlorite. And there are different ways to increase the temperature of sodium hypochlorite. One is by using coffee cups like this. You can put the sodium hypochlorite syringes into these coffee cups and keep them warm. And you also have commercially available devices like these, where you can insert the loaded syringes into slots which are provided. These are quite similar to the composite syringe warmers. Another way of applying heat to sodium hypochlorite is injecting sodium hypochlorite into the canal and then putting some sort of an instrument which transfers heat into the solution. You can do this with devices like System B or touch and heat obturation devices which transfer heat from the tip. Or you can also use ultrasonics with a water supply cutoff. You put sodium hypochlorite into the canal and then apply ultrasonics into the sodium hypochlorite. And both of these will transfer heat into a sodium hypochlorite, thereby enhancing its efficacy. Another advantage of using sonics and ultrasonics is something called acoustic streaming, which is these sort of patterns which develop, which enhances irrigation. So that's the other advantage of using ultrasonics, not just heat, but also acoustic streaming. One factor we need to consider is the tissue dissolution of sodium hypochlorite. So if you want sodium hypochlorite to completely digest pulp tissue, it usually takes about 40 minutes. These are some pictures shared by Dr. Nadeem Ahmed. You can see how the pulp tissue is when you remove it from the tooth. You insert it 5 minutes into sodium hypochlorite. You can see there's some amount of dissolution, but even at 45 minutes, there's still some debris. So one can't rely on sodium hypochlorite completely ingesting pulp tissue. It has to be a combination of exchange of fluid. So you want to put the sodium hypochlorite, wait for it to digest some pulp, and once the loose tissue comes into solution, you want to keep introducing sodium hypochlorite. So you keep replenishing the sodium hypochlorite so that you get some irrigant flow in the canal. One has to remember that sodium hypochlorite does not selectively distinguish between pulp tissue and periapical tissue. So if one is careless and extrudes sodium hypochlorite into the periapical region, there can be pretty nasty reactions. So one has to be extremely careful, and one needs to know why extrusion happens in the first place. The reason why extrusion happens is when one jams the needle into the canal, then the rest of the canal acts as an extension of this needle. So the needle is jammed tight in the canal, and then when the clinician exerts pressure and the irrigant is introduced into the canal, the rest of the canal will act as an extension of this needle, and the hypochlorite gets extruded into the periapical tissues. So this is the reason for extrusion. And there is a very easy way to solve this. All you need to do is not jam the needle into the canal space. So when one puts the needle into the canal, always try and retract it. And if there is resistance to retraction, then don't inject the solution. Retract it, and the needle should fit loosely in the canal like this. It should not be contacting the walls of the canal or be tightly fit. And if you do that, then you minimize chances of extrusion. The other factor that can prevent extrusion is to use what we call side vented needles. So rather than needles where the irrigant is extruded at the tip, you have side vented needles. So a combination of these two, making sure that the needle is not tightly fit in the canal and using side vented needles will prevent apical extrusion of sodium hypochlorite. Of course, rubber dam is an essential part of endodontics. We should use it for all aspects of endodontics. It becomes even more relevant when we talk about sodium hypochlorite, because if you don't seal the oral tissues and you allow sodium hypochlorite to leak, then you can injure the patient's oral tissues. So you want to use a rubber dam like you see here. And in addition to using the rubber dam, if there are spaces between the rubber dam and the tooth, then you can seal that with some sort of a gingival protective barrier like opal dam or any sort of a gingival protection barrier that you get commercially. You can use that to seal those spaces around the tooth so that even if some hypochlorite leaks out from here, it doesn't go and harm the oral tissues around. So this is really, really important. By the way, if you are someone who doesn't know how to do single tooth isolation for endodontics, then do let me know in the comments and I'll be happy to make a video for you on how to do single tooth isolation for clinical endodontics. It's something that's really easy. You can pick it up in just half an hour within 3 or 4 cases. One more thing you have to be really careful is when you use sodium hypochlorite, even a small drop, if it falls, especially on darker clothes like the one I'm wearing right now, it can stain dark clothes like this. You can get these sort of yellowish, whitish stains, and once it happens, it's very, very difficult and can get very embarrassing. Endodontists wear it like a badge of honor if you have hypochlorite stains. But what's even more embarrassing is if the patient comes in with a really expensive jacket or a shirt and then the assistant or you are careless and one small drop falls on your shirt, then you can get stains like these. So you want to be really careful. And like I said, it's always a good habit to use these sort of red syringes. So even the assistant, when he or she passes the syringe filled with sodium hypochlorite, they're aware that it is hypochlorite. So you pass it in such a way that even a drop doesn't fall on the patient's dress and kind of damage it irreversibly, especially if it's an expensive dress. The next solution we use in clinical endodontics is EDTA, and the concentration is 17% EDTA. Why do we use EDTA? We primarily use it to remove the inorganic part of the smear layer. Now, what is a smear layer? Whenever the dentine is exposed to some sort of a mechanical factor, then you get this layer of debris which kind of clogs the dentinal tubules. You get something called a smear plug. And this is how a cross section looks like. This is a smear layer covering the dental tubules. And once you use 17% EDTA, this is how it looks. All the tubules are open. Sodium hypochlorite will remove the organic components of the smear layer, but the inorganic components are removed by 17% EDTA. It doesn't need a lot of time. You need less than a minute. So we use that to remove the smear layer. The third irrigant we use is chlorhexidine. Chlorhexidine 2% is what we use in clinical practice. When do we use it and why do we use it? It has a very strong activity against gram-positive cocci. It doesn't have much activity against gram-negative anaerobes. It is particularly effective against what we call E. faecalis, which is gram-positive. And it has a very interesting property called substantivity. Substantivity is the ability of a chemical agent to bind to a surface and continue exerting its effect over time, even after the solution itself is removed. So after you inject chlorhexidine into the canal, and you dry the canals, a part of this chlorhexidine clings to the dentinal walls, exerting some sort of an antibacterial action over a prolonged period of time. However, one has to remember that it does not have any tissue dissolution properties and therefore cannot be used as a primary irrigant. Chlorhexidine is more effective against gram-positive bacteria rather than gram-negative. And where do you find gram-positive bacteria? You usually find it in failed cases or retreatment cases. And we usually use chlorhexidine in those cases, not for vital cases. It's important to remember that you don't want to mix irrigants. You don't want to mix sodium hypochlorite with either EDTA or chlorhexidine. And there's a reason for that, especially sodium hypochlorite and chlorhexidine. If you mix these two together, you get a really thick reddish precipitate. It's called parachloroaniline, PCA, which compromises root canal treatment by staining teeth. This is how it looks. This is hypochlorite. And you add chlorhexidine, it turns orangish, brownish like this. And once it turns like this in the canal, it stains the dentine and it's almost impossible to remove. It's an absolute nightmare. So you don't want to do that. You want to introduce some sort of a solution in between sodium hypochlorite and chlorhexidine. Typically, it's water and EDTA. We use both and only then introduce chlorhexidine. So these are the interactions. It's not just chlorhexidine. Even EDTA can interact with sodium hypochlorite. So this is sodium hypochlorite. If you introduce EDTA, then it kind of forms this whitish precipitate. It's not as bad as this precipitate when you mix it with chlorhexidine, but still, even this, you don't want it to happen. So make sure that you have water as an interface when you use one irrigant after the other. So what's a good sequence to have for routine clinical practice? To start with, sodium hypochlorite is the primary irrigant. We use sodium hypochlorite continuously, copiously. We use it continuously, but we don't introduce any other irrigant. We use it till the stage where the master cone is selected. Once the master cone is selected and we are about to obturate, that's when we introduce some water first. We rinse the canals with water, carry water with the master cone to working length into the canal, and then we leave it for a minute. The goal is to try and neutralize whatever hypochlorite is there in the canal. And then we rinse with 17% EDTA in the canal, carry EDTA with master cone to working length into the canal, and then leave it for a minute. So you want to leave the EDTA in the canal for approximately a minute so that you get enough time to remove the inorganic components of the smear layer. Once that is done, you want to neutralize the EDTA that's in the canal. So again, you rinse with water and you carry the water with master cone to working length into the canal, rinse copiously with water, and then leave it for a minute. Now at this stage, if you are dealing with a vital teeth, then you can go ahead and obturate. But if you are dealing with a non-vital teeth or a resistant case or a retreatment case, then you can introduce chlorhexidine into the canal. So you do your final rinse with 2% chlorhexidine for 1 minute, carry with the master cone to working length, leave it for a minute, and then you decide whether you're going to obturate the case or are you going to put some calcium hydroxide or something. So in resistant cases or retreatment cases where the initial treatment hasn't worked and you know that there are chances for some sort of a gram-positive bacteria, resistant bacteria, E. faecalis, then we use chlorhexidine as an additional disinfectant to hopefully work on those bacteria which are resistant to routine endodontic therapy. Just a quick word about something called the vapor lock. Now, what is the vapor lock? When someone irrigates the canal, because these canals are closed spaces, when we irrigate, there is a limitation as to how far down the root the irrigant is going to flow. So typically, an irrigant will not flow 1 to 2 millimeters beyond the tip of the needle, right? So once that is done, there will be a certain part of the root where the irrigant doesn't reach. So you have air that is trapped here, and you have an irrigant which goes into the canal and then flows coronally, doesn't reach the apical area. This is known as vapor lock. So this will result in air being trapped in the apical part of the canal and the irrigant not flowing all the way to the apex. So this is something that we have to deal with. Now, people have suggested all kinds of techniques to overcome this, but it is still doubtful whether or not you can replicate that in clinical practice. So there is a real danger that most of your irrigants are probably not going to reach the apex because of this vapor lock. Especially these days with these conservative preparations. Back in the days, we used to have these larger preparations. So when you have larger preparations, you have a much better chance of the irrigant breaking through this vapor lock and then reaching the apex. But these days, the trend is more towards conservative preparations, and the more conservative your preparation, then lesser your chances of removing this vapor lock and the irrigant reaching the apex. So this is something that we have to live with. And companies have been trying to remove this vapor lock for ages. Most of the innovations have been efforts to remove this and sort of create this environment where the irrigant can flow freely, where this air is removed, and you create some sort of an environment, something called a negative pressure device. What is a negative pressure device? So you have two components. One is where the irrigant flows into the canal, and then you have another component which aspirates the irrigant along with the air in the canal. So this cycle will ensure that the irrigant reaches the apex. At least in theory, this is the effort. So you have a lot of devices. It started with this device called the Endovac, and now you have something called gentle wave. Now, all these are efforts. Some people say that it's effective, and then on the other hand, you have the skeptics who say that it doesn't make a difference. So most of the technology or developments has been an effort to remove this vapor lock inside and create some sort of a negative pressure inside, where you ensure that the irrigant flows to all these nooks and crannies in the root canal. So that, in a nutshell, is everything you need to know about endodontic irrigation. Like I said, if you want a free PDF which summarizes everything we talked about, then do check out the link in the description below. I've put together a completely free PDF which you can download, keep on your phone or in your clinic, and refer whenever you have some sort of a doubt with endodontic irrigation. If you enjoyed that content, then maybe you would enjoy my weekly newsletter, which is a short email that I send out every Wednesday. is usually filled with some useful dental and non-dental information. I've put the link in the description below. Do have a look and subscribe to my weekly newsletter called Wisdom Wednesdays. Don't forget to click on that subscribe button so that you get notified every time I upload a new video, which is usually every Sunday. And if you enjoy content like this, then maybe you should check out some of my other videos on this channel coming up over here. I'll see you next week with another video. Till then, take care. Thanks for watching.